Evening, everybody. Probably after 3 weeks, we are having a live session through my website. Today, we are going to discuss about the presentation about the exams of thyroid, and we in specific discuss about the carcinoma thyroid. I I welcome Professor V Manoharan Sir, ex-HOD from Manakola Vinayagar Medical College and Hospital. Sir is very close to me, quite senior to me, very academician, and actually regularly he sent me good quotations. I'm rather inspired by his academic and his regular academic activities. Sir, I welcome you, sir. Uh, I welcome Professor and HOD Dr. Gopinath Pai from KVG Medical College, India. We did almost together MS in KMC Mangalore. Uh, my colleague, my good friend, we are regularly in touch with each other, and again a very good academician. He always be there with us for all CME activities. Dr. Gopinath Pai, I welcome you for the session. Thank you very much. And I welcome my dear friend Dr. Robin, quite close to me, always there with my all sessions, very scintillating and discusses very nicely. He's from Pushpagiri Medical College, so professor and in general surgery and laparoscopic surgery from Tiruvalla. Robin, very nice to see you. Welcome you again. Uh, I welcome my dear friend Keshav Prasad, professor from the KVG Medical College. He did his MS and MBBS in KMC Mangalore rather long ago, 15, 18 years back. A good, very good surgeon, laparoscopy surgeon, very academician, a scintillating surgeon, and my good friend Keshav. Welcome you very much. And today's presenter, Disha, final year student from my college, KMC Mangalore. Chandan, from again my final year student from my college, KMC Mangalore. They are going to, I welcome them, and they are going to present exams of thyroid from our unit case. We'll over to presentation straight away without discussing much. Straight away, we'll go for presentation. Disha, I think, presenting the history. Chandan will take over for the examination. So we'll discuss presentation over to Disha. Robin, Robin will discuss presentation straight away. Benny, over to you for slide.
So we'll be presenting about the thyroid neck swelling. Next page and next slide. Mrs. X, a 54-year-old female hailing from Putturu, Dakshin Kannada, who is a homemaker, presented with the following swelling in front of the neck since she was 18 years of age, being stressed and tensed, unable to sleep, increased sweating, palpitations for last 3 months. Next slide. History of presenting illness. Patient's relatives and friends noticed a swelling in patient's neck when she was 18 years old. The swelling was insidious in onset, gradually progressing from approximately 2 into 2 centimeter swelling at the center of the neck to an irregular swelling, largest in the right side of the neck. The swelling wasn't associated with pain. She also complains of getting stressed, tensed, increased sweating, unable to sleep, and palpitations since 3 months. There was no history of hoarseness, dyspnea, and dysphagia. There was no history of exertional chest pain and swelling of ankles. There was no history of weight gain, alopecia, constipation, increased sleep, cold intolerance, and increased fatigue ability. There was no history of sudden weight loss and loss of appetite. The past medical history: patient had multiple episodes of seizures from the last 15 years for which she was on tablet levetiracetam 2 times a day she takes. For palpitations, she is on tablet propranolol. She doesn't have any other comorbidities like diabetes mellitus and hypertension. She is not on any anti-thyroid medication. She had no history of irradiation to head and neck in the childhood. Past surgical history: 15 years back, she had a benign mass for which she had to undergo hysterectomy. It was in the genital tract. No previous thyroid surgeries. Menstrual history: menarche was attained at menstrual. She had regular cycles of 30 days with bleeding for 5 to 6 days. Her Her obstetric score was P1L1. 15 years ago, she was diagnosed with benign mass in the genital tract and had to undergo hysterectomy. She stopped bleeding at the age of 39 after hysterectomy. So this is the family history. There was no complaints of neck swelling in the family, and this is 3-generation pedigree chart of her family. Next slide. Personal history. She consumes vegetarian diet. She eats cabbage rarely. Appetite is normal. Sleep disturbed due to anxiety and palpitation. And there is increased frequency of bowel movements. Bladder movements are normal. No history of smoking or alcohol consumption. Next slide. So the summary of the history. A 54-year-old female from Puttur came with chief complaints of swelling in front of neck from 18 years of age and anxiety, increased sweating, palpitations, and unable to sleep since 3 months. There was no features of hypothyroidism and malignancy. She had history of multiple Sheath episodes since last 15 years. She is on medications for the same. There was no history of comorbidities present. She has history of hysterectomy following a benign mass. There is increased frequency of passing stools and sleep is disturbed.
We'll go back to the okay. We finish up this one, Disha.
So our provisional diagnosis is a benign thyroid swelling, which is a non-toxic in nature.
Okay, wait. Robin will go back to the history, I think, just quickly.
Yes.
When we go back to the chief complaint. First slide. This is the first one, I think. Okay, one more. Back. Vinny, can you go back? Yeah, this one. Sir, anything to comment, sir? He said being stressed and tense, unable to sleep. But she says it is a non-toxic by this one. There are a few features of toxicity also, but we concluded as a non-toxic it is. Anything to comment, Manoharan Sir?
So, long-standing pre-existing swelling, sir. Symptomatic since 3 months, and she has that insomnia and increased sweating and palpitations also. Sir.
Yes.
This point suggests you of secondary thyrotoxicosis. So all features are not there, and plus she has increased bowel movements also.
Bowel movements also. That's what that history, because they have not taken into consideration. Even the history they have taken properly, but they have applied it to this. Next slide, Gopi.
With the history of palpitation and anxiety, I think one has to think in terms of toxic condition in this particular patient.
Next slide. Next slide. Anything to comment on this, Robin?
Sir, with the permission of Gobi sir and Manoharan sir, they're very senior to me, so may I ask a few questions, if you don't mind?
Okay, no problem.
Disha.
Yes, sir.
Disha, this, from chief complaints, whenever from DAS itself, from patients' own words, inpatients' own words, that's the whole point. Now, the swelling was insidious in onset, gradually progressing from approximately 2 into 2 centimeter swelling. Did the patient actually say, I have a 2 into 2 centimeter swelling, or they've described it in some other form?
She showed it like this.
Exactly, that's the whole point. You're absolutely right. So there's a finger breath, na?
Yes.
The one you describe it in some sort of finger breath. That's how it is in DAS also, na? Because this approximately 2 into 2, you will get ragged for no reason. Then again, next is to an irregular swelling. Did the patient say the shape of the swelling, margins of the swelling?
She just told that it has been present over like this. She didn't describe it as irregular, but she
Irregular, exactly. So the whole point is when you go for you complete everything from Socrates, the site of the swelling, where was it initially seen? Since 18 years, this patient is carrying this thing.
yes,
Onset of it, you have an acute onset, which is sudden in nature. You have a gradually progressing one, which is a chronic pathology, and you have some. Supposing it's malignancy, we use a term called insidious. So we
yes,
don't interchange both in between. These are usual things that we follow. Character of the swelling. How was it initially? Which you said it was one finger breadth in size, but when? And over a period of what time did it develop into two or three finger breadths? So the what's the inference is we are trying to tell is the evolution of the goiter. This child, this particular patient, since 18 years she's been carrying it. What if it started off as a diffuse hyperplastic goiter and gradually over a period of time it has become something? Now, if you explain that way, an irregular would be a poculated swelling. It would have become a multinodular. Like Manoharan Sir has already said, already there's a pre-existing goiter, a swelling. Then she developed the symptoms. So these are very important points we follow. Then relieving aggravating factors, okay, not very significant here for the time being. The extent of the swelling, from where to where, very important. So you finished half of Socrates. Then the next associated symptoms, swelling wasn't associated with pain. Now you have already mentioned positive findings. Don't you think you should complete that first? The patient is having a stressful nature. So how do you quantify it? How did you figure out? How did the patient tell you that I am stressed, I am tense, I'm having increased sweating, I'm unable to sleep? But when? These are very important. Nah? Now, palpitations. See, we are in surgery. Palpitation comes in internal medicine also. What are the causes for surgical palpitation?
Whether it is relevant to this condition or not. That's what
Yeah,
just
that's the whole point.
give a conclusion. Because you said it is not relevant to this condition.
No, in other words, whether palpitations is at rest or following some
Yes,
physical activity,
yes.
or even at while sleeping when she is at home. So that part you should little elaborate.
Whether it is continuously there palpitation.
Continuously is there or following
Yes.
some
So
physical
little
activity.
more detail of that history should be taken. That's what.
Yes, because these are positive findings. This particular young person from young age, she's been having it. So you have to quantify and you have to qualify. Both the things you have to tell us.
okay,
And I think the words like stress and tense, I think you have to be a bit more specific. Like, matlab, you have to tell how did the patient describe it to you? The patient comes to you. How did he describe? Now, the minute the patient walks into your OPD door, you notice few things, right? She's
yes,
restless, she's
yes,
anxious, she's tense, she's fidgety. These sort of things are some simple words that the patient will say. Restlessness. So increased sweating. Even here there is importance. What about the quality of sweating? Not quantity, quality as in heat intolerance, cold intolerance. Is the patient sweating in sitting in the AC under the fan? Or is it on exertion? Is it at rest? So all these things come in your history of presentation of 1.5 pages.
okay, sir.
Unable to sleep, again very important when it comes to thyroid toxicosis and hypothyroidism. When was it more? Unable to sleep since how long? Since 18 years the patient is not even able to sleep, or since 3 months this problem is going on.
No,
Agreed. Do you actually do you think any patient would not sleep for 3 months? So you'll have to be very, yeah, you have to be very specific, because that these are very important points.
Yes,
So
sir.
we have to ask you some
One
questions.
more thing,
And
Disha.
yeah,
You said all these complaints 3 months.
It is only
You
for
mean to say 3 months before she was absolutely all right? Then just before 3 months, everything started. So something started first. You understand? So
Yes, sir.
gradually, one after another, probably she remembers that way.
maybe which one
You have
started
to do a little bit of probing
has increased.
to find out what exactly happened first, then what happened next, like that. Understand? Just before 3 months, she was all right. Just after 3 months, everything started. That is something which is not correlating.
Yes, sir.
You understand?
Yes, sir.
Disha,
Disha, why you asked
the
pain?
swelling is associated with pain. Suppose all these symptoms, can it occur with pain?
Um,
What do you think? What is the probable cause?
actually, the thyroid swellings are painless, but some conditions like inflammatory, that is the thyroiditis, or hemorrhage inside the thyroid gland can cause pain, and rarely in the anaplastic carcinoma, when it infiltrates the nerves, there also there will be pain. Apart from that, pain is little uncommon in the thyroid swellings.
Symptoms of pain associated with what all complaints you have narrated now,
Oh,
like
sorry,
getting stress,
the direct question. Direct
yeah,
question.
more likely with the thyroiditis, isn't it? Can you think of any name for this thyroiditis?
Uh, Hashimoto's thyroiditis.
Okay, good.
Keshav, anything? Next slide, Benny. Next slide, Benny. Okay. You said off-night dyspnea, dysphagia, no exact pain, no swelling of ankles, no. You also told weight gain, alopecia, constipation, increased sleep, cold intolerance because probably features of hyperthyroidism. Why this sudden weight loss and loss of appetite?
To rule out any malignancy, the changes of the primary thing to the
See, you should know that not every malignancy there will be weight loss. Just because it is malignancy, in certain lip carcinoma, there is a small swelling in the lip. You think the patient will have weight loss?
That is what Keshav has absolutely told, because in surface malignancy, like in breast carcinoma, thyroid carcinoma, or surface sarcomas, unless it is metastatic or visceral spread, it won't cause loss of weight loss. But toxic thyroid can cause.
I would be happy if you tell you are thinking of weight loss due to toxicity. And in that case, the appetite will be increased. The only two conditions where the appetite is more but there is weight loss.
Yeah.
One is
So,
toxicity. Other one is
what other condition where
appetite is increased but there is weight loss. Very common condition. Diabetes.
diabetes?
No, you didn't, but regarding appetite, is there any increase in appetite?
no, sir.
What?
That's very specifically mentioned.
Disha and Chandan, Keshav has rightly pointed out, in a toxic thyroid that increase appetite but weight loss. Understood? No. Whereas you are telling loss of appetite, you are interested in finding out loss of appetite and loss of weight. So in a surface malignancy, unless it is metastatic, it won't happen. Understood? In a like carcinoma, breast in early type, in surface malignancy, it won't. Unless there is a visceral spread. You understood, no? Why that is that relevancy you should be able to always find out and express. Okay. So
Okay.
Dr. Keshav Prasad wanted to know. Okay. Next slide, Benny. Chandan, in between, you can also answer. You can help her. No issue. Okay.
Yes.
You said the palpitation. She is taking medicine. No.
Yes, sir.
Oh, right.
The timing of medicine is important. Is she having palpitation despite taking propranolol?
Right now, she is not having.
See, that's where if you're see this is mentioned. She's taking propranolol since how long?
Since 3 months.
Exactly. If you're telling she's taking already propranolol from 3 months, how is she having palpitations in 3
That's
months?
what. Disha, have you asked whether she is assessed for thyroid function?
What is the sequence of treatment? In the sense now she's having 18 years this swelling.
Yes, sir.
So 18 years, what has she done for 18 years? At least you would have shown somebody, or of recent. Why somebody will simply put a patient on propranolol? So she was probably hydrated. So that history should come, no?
Right. Why irradiation to head and neck in childhood?
Causing
It is.
carcinoma in the later phase of the life.
Okay. Okay. I think we commonly ask this for Robin. Is usually will ask for which conditions at least they were giving irradiation in head and neck.
Before like not now,
Downward.
using it for this adenoids, tonsillitis.
Non-Hodgkin lymphomas.
Now they are using it for lymphomas like Hodgkin's lymphoma.
Okay, fair enough. Next slide, Benny. Okay, she had benign mass of whether it's relevant to this? No previous thyroid surgery, hysterectomy, and thyroid. I'm just asking.
There might be presence of stroma over eye.
Okay, not much.
Hysterectomy, not ovarectomy.
Hysterectomy, they have done hysterectomy for something else. You said benign mass. Okay,
Can you
stroma,
think
stroma
of
ovary.
any syndrome which has
With that, any syndrome is relevant to this? What is stroma ovary?
Ectopic thyroid present in the ovary.
Is functioning. Functioning thyroid.
Functioning thyroid.
Functions and it causes thyrotoxicosis.
Okay. Next slide. Okay. So, Gopi, anything to add on to this? Any comment on this slide?
So benign mass probably it is fibroid, let us assume.
Okay. That's
Second thing is stopped bleeding means what? You mean to say attain menopause?
yeah,
Yes,
it's a very vague term.
that last sentence you better to avoid, because after hysterectomy, naturally they will attain no. So
It is
it's not logically understood. So you better to not put the such words sentences. Okay.
Okay,
Next,
sir.
next slide.
It's a very vague, sentence. Like she stopped bleeding a day.
At the
It's
year
not
of
very
after
beautiful.
hysterectomy, naturally they'll stop. No,
Yes, sir. Yes.
they don't require to
It's
express that. Okay.
So after
very
hysterectomy,
relevant to your case. Yeah.
what Disha? After hysterectomy, there is no uterus.
Yes.
How do you expect to bleed?
Sorry.
No endometrium, no.
So
Right.
such
Okay.
sentence should be avoided, Disha. Okay. Next
Yes.
one. Next slide. Okay. Family history. All those family tree, everything is there. She has put. That's very important. Family history for thyroid. Remember, three generation family history. Siblings, how many parents, anybody is having, how many children. Every detail you have to put. Okay. Next slide.
Chandan, sir, may I
Sir.
ask you just a question? Chandan, she's given a very good pedigree chart.
Go back.
And can you give us? There are 4 familial cancer syndromes associated with thyroid. Can you give us at least 2?
Chandan, you understood question, no? Why this is
Yes.
relevant? Give some syndrome, at least give name 2 syndromes relevant to this.
Very common, which is seen in the
Like
endocrine system, not only thyroid.
men too, sir.
Men too.
Okay, that is for medullary carcinoma thyroid.
That
Okay,
is medullary.
parafollicular C cells. Okay, but thyroid itself,
For differentiated thyroid carcinoma.
DTC, different thyroid cancer.
Yes.
Yeah,
Yes. Different.
can you take the question? You have put a very detailed family tree. It's very nice.
Yes, sir, yeah. There are 4. Just give us 2, or at least give us 1. It's very common. When you read even breast, it is there as a in the predisposing risk factors.
Almost every malignancy it is there.
Yes, almost every malignancy. Sir is right.
Almost every malignancy is there.
Heard about any syndromes, Disha? The syndrome.
Cowden syndrome, sir.
Cowden syndrome. One.
There are
absolutely
3 syndromes, 1 complex. Very easy to remember. You are not. It's not PG discussion, so we are not going to. But Cowden syndrome is 1. Yes, very good. You should know which of these syndromes and complex where you have papillary thyroid mainly, where you have papillary thyroid and follicular mainly, where you have follicular predominant, and then it's very interesting to note that.
Yeah.
Thank you, sir.
Ravi, you can just highlight these syndromes briefly for.
Yes, sir. I'll put in the group also. Yeah. Yes.
Sir, another one is Werner's.
Yes, very good. Verma syndrome. I told you there are 3 syndromes, 1 complex. Can you give us the complex?
Absolutely right. Oh, you are good. That's good. Any more? Robin, you can give the answer.
Sir, Carnes.
Yes, very good. Yes, Carney complex. Yes, very good.
Absolutely.
Carney complex. Yes, absolutely right. It's good enough. Yes, yes.
Good enough.
So we can go to next. Yes.
Next slide.
Very good. Yes.
Okay. And anything to add on to this, Gopi or Keshav? Robin? Bowel movement, she has told, bladder movement, no history of smoking, alcohol consumption. Okay, appetite is normal. Vegetarian diet, it's cabbage rarely. Why you specified cabbage rarely? Whether it is need to
Presence of loose stools normal appetite, no loss of weight. How can you explain this?
No loss of weight. How it is explained? You said palpitation, other things are there. No loose stool is there. No loss of weight. So how it is? How you will explain it? Dr. Gopinath face question.
Sir, there's no significant loss of weight, sir.
Okay.
Like in the past 3 months or so, the body weight has been remained same.
Okay. Okay. Next slide. We'll go to the next slide. Okay, that issue of certain mass, increasing passing stool, sleepy disturbed. That's everything you have mentioned. We have discussed all those things. Unable to sleep for since next month. The orderly you have to put. That's what Robin and Manoharan Sir has told. And the diarrhea, about diarrhea, lose to little more detail. Gopinath Pai has mentioned. Next slide. Any next slide. Now you said it is non-toxic. You said 18 years the swelling is there, nodules are there. You thought it not. Probably it is not even not examined.
Sir, the cardinal signs of being a toxic swelling is tremors and having a brewy.
No. This history was
We are in history taking.
your history taking.
Brewery is examination.
There you said the sleep is disturbed, sweating is there. Actually, to suspect 3 months duration, previous long history of thyroid. You tell what are the complications of multinodal goiter?
It can cause follicular carcinoma.
Okay.
Is that the most common complication of multinodal
Common
goiter?
complication.
Most common.
Secondary thyrotoxicosis.
Secondary thyrotoxicosis. That's the most common. Second common is follicular carcinoma thyroid. Then you have bleeding, calcification, this formation. Yes.
All the things are there. So there may be 3 complications.
So
So
in negative history, you should mention about eye signs also. At least no examples. So you mentioned no malignancy, no signs of this thing and all. So many things you said. But always when you mention it is so confidently you're telling non-toxic. So you should mention there is no tremors or at least no examples. That will add to your presentation. Okay.
So Gopinath, Robin will go for the examination.
Sure.
Yeah.
Sure, sir.
Any next slide? Chandan.
So coming to general physical examination, patient is conscious, cooperative, and well-oriented to time, place, and person. The patient weighs 36 kgs, height 150 centimeters. And so the body mass index comes to 16 kg per meter square. She's moderately built and well nourished. Vitals, coming to vitals, blood pressure is 118 by 80 mm of Hg in right arm sitting position. Pulse rate is 78 beats per minute, normal rate, rhythm, volume, and character. No radial delay, and all peripheral pulses were felt. Respiratory rate 16 cycles per minute, and thorac-abdomen type. Next slide. So pallor was present in the lower palpebral conjunctiva. No icterus, cyanosis, clubbing, and edema. No generalized lymphadenopathy. No positive eye signs. Coming to local examination, the examination was done with consent in a well-lit room with privacy and was done with adequate exposure to the area to be examined. Examination was done in sitting position. Next. The swelling involved both lobes of thyroid, including the isthmus. It extended horizontally between sternocleidomastoid muscles of both sides. Vertically in the right side, approximately 2 centimeter laterally at the level of thyroid cartilage to 1 centimeter above sternoclavicular joint. At midline, it extends between 2 centimeter below thyroid cartilage to about 0.5 centimeter above sternal notch. And in the left side, between 4 centimeter lateral and below thyroid cartilage to 1 centimeter above the left sternoclavicular joint. Surface of the swelling appears nodular. Next. The swelling had well-defined borders. Skin over swelling appears normal. Swelling moves with deglutition and lower border is appreciated. Trachea is not visualized due to swelling. Pemberton sign absent. Next. Next slide. So on palpation, there is no local rise of temperature over the swelling. The swelling was non-tender. The right lobe measures 10 into 7 centimeter. The left lobe measures 7 into 6 centimeter. At the isthmus, it measures around 6 into 6 centimeter. Next slide. The shape is irregular. It extends horizontally between the sternocleidomastoid muscles of both sides. Vertically in the right lobe, 2.5 centimeter laterally at the level of thyroid cartilage to 1.3 centimeter above sternoclavicular joint. At isthmus, it extends between 2.4 centimeter below thyroid cartilage to 0.7 centimeter above sternal notch. And in the left lobe, between 3.8 centimeter lateral and below thyroid cartilage to 1.2 centimeter above left sternoclavicular joint. On palpation, the consistency varied from smooth to firm. The borders were well defined and lower border was felt. Multiple nodules palpated. The swelling was not fixed both horizontally and vertically. Carotid pulse was felt. Cervical lymph nodes not palpable. On percussion, over sternum, resonant note was heard. On auscultation, no bruit was heard. Next. And systemic examination, coming to cardiovascular system, S1 and S2 sounds were heard and no murmurs noted. In respiratory system, normal vesicular breath sounds in all lung areas. In central nervous system, no focal deficit were found. On per examination, normal bowel sound heard and no organomegaly noticed. So summarizing as a whole case, a 54-year-old female from Puttur came with chief complaints of swelling in front of neck from 18 years of age and anxiety, increased sweating, palpitation, and unable to sleep since 3 months. No features of hypothyroidism and malignancy. She has history of seizure episodes since last 15 years and is on medication for the same. She has history of hysterectomy following a benign mass. There is increased frequency of passing stools and sleep is disturbed. Next. Pallor present in lower palpebral conjunctiva. The swelling involved both lobes of thyroid, including the isthmus. The shape of the swelling is irregular. It extended horizontally between the sternocleidomastoid muscles of both sides. Vertically in the right lobe, 2.5 centimeter laterally at the level of thyroid cartilage to 1.3 centimeter above sternoclavicular joint. At isthmus, it extends between 2.4 centimeter below thyroid cartilage to 0.7 centimeter above sternal notch. And in the left lobe, between 3.8 centimeter lateral and below thyroid cartilage to 1.2 centimeter above left sternoclavicular joint. The consistency varied from smooth to firm. The borders were well defined and lower border was also felt. Multiple nodules palpated and the swelling was not fixed both horizontally and vertically, and the carotid pulse was felt.
Next.
So the provisional diagnosis is multinodular goiter, previously in hyperthyroid state, now in euthyroid state. So
Later. We'll
yes.
go back to local examination. Vinny, quickly go to the local examination. Maybe general examination. One more back. You said eye signs. Where you have mentioned eye signs.
Next slide.
Pulse rate, everything you have mentioned.
See, it's mentioned moderately built and nourished. Patient looks a little thin only for me. So 3 months, this thing. So you should have asked within 3 months whether there is some marginal loss at least. Definitely.
She said that her weight has remained same since the past year, sir. So there's no immediate loss of weight.
So you have asked.
Yes, sir.
Good. Next.
Okay, what is sleeping pulse rate?
The pulse rate that is measured at early morning or at just before the sleep, sir, and in thyroid cases, it will be.
Just will you agree with him? When you will check the sleeping pulse rate?
When we're suspecting any primary hyperthyroid states.
Toxic thyroid. When you're suffering toxic thyroid, you check the pulse rate, whether primary or
Yes.
secondary. Whatever.
Yes.
But what time will check? How exactly will do the method clinical examination to confirm the sleeping pulse rate?
Sir,
Does the
clinically
patient need to sleep?
we can induce sleep, sir, and then measure the pulse using medications.
Which medicine you will give?
The benzodiazepines.
Disha, you have got any idea sleeping pulse rate, when to check, how to check?
No, sir.
Oh, okay.
Okay, tell me why you should say sleeping pulse, sir?
Why you want to check sleeping?
What is the
There is
reason?
a variation in the pulse rate during sleep in primary.
So why should you see while he is sleeping? Chandan, any idea?
You should not be awakened. That's important. What are the grading called as sleeping pulse rate grading in toxic thyroid? Have you heard about it?
Greater, less than 90,
Greatest, yes.
110 is grade 2, and greater than 110 is grade 3.
What is that grading called? Any name for that?
Greatest.
What?
Scales,
Trials grading. Okay. Trials grading it is. Okay. So in midnight we check. There is a controversy whether you use sedation or not, and patient should not get up, awaken. But only problem is we are very sensitive. When you touch, they'll get up. Because they're toxic. That's the problem. But the 3 consecutive nights you have to check. Then take an average. That's how exactly we'll do that. Okay. So next slide.
As per literature, the NREM sleep.
NREM sleep. Yeah, sorry, that's what.
NREM sleep in post midnight, the ward nurse has to be instructed.
Yeah.
So she is the one who will know when he is sleeping.
He goes for a deep sleep. You check. Then you take without awakening the patient.
Yes, sir. The earlier stages, that was the only gold standard bedside clinical parameter to assess the improvement in toxicity. Who is on antithyroid drugs?
Okay.
Those days. But nowadays, of course, we don't
Positive
follow.
eye signs. Which eye signs you look for usually in a toxic thyroid? There are so many, around 20. That is not necessary for you. Remember 4 eye signs. Usually. What are they?
Stelvax, sir. The staring, no blinking of,
Okay.
and Joffrey signs, sir. The absence of forehead wrinkling on raising of eyebrows, sir.
Okay. You have to
Joffrey.
flex the neck. You have to flex the neck and check the raising. Not raise.
Yes.
Ask the patient flex it by this. Then ask the patient to raise the eyebrow. That's it.
Yes.
Okay.
Then lid retraction, lid lag.
One grief sign. How to do that?
The patient's
Patient follow like this. Follow your finger
Yes.
like this. That is sufficient. If the patient follow, that is sufficient. Then it's Mobius sign like this. Convergence. 4 signs you have to look for. All other things is academic interest. So these 4 signs, if you remember, for Nabzygers you have to know. I think from behind you check whether protrusion of the eyelid is there or not.
Yes. Exophthalmos is checked.
Gopi, you will agree with this that 3-4 signs are sufficient. I think they.
Yes, 4 signs are sufficient.
How many other around 20 signs are there even in my
Yeah,
book?
20 other. Yes, sir. Yes,
That
sir.
is-
There are 20. There are 2 mild, 1 moderate, and 1 severe is more than enough to know the severity of the eye signs.
Signs, yeah.
Chandan and Disha, see, whenever you present, don't it's like no positive eye signs. What does it mean by that? Eye signs are present or absent? No.
Absent.
See, it's a case of thyroid. Yeah, it's present or absent. Whatever is there, you just mentioned like
Yeah,
no
that is
staring
not-
look, no
not-
lid
that is
like
not
present.
positive, negative. Eye signs
There
are
is no
not
positive or negative.
Yes.
eye signs are absent or eye signs are not present. Okay.
Yes.
Right. So next slide.
The signs are always present or absent. Test is positive or negative.
But something about edema of the legs. Tell me what is the nature of edema which occurs in toxicosis? What is the nature of edema which occurs in secondary toxicosis?
Pretibial mixed edema in primary.
Very good. Secondary? Secondary due to what?
Dependent parts will get due
Due
to
to what?
Due to
cardiac failure.
cardiac cause.
Cardiac cause. Absolutely right.
So
Okay.
clinically you must say non-pitting edema.
Yeah. Mixed edema,
Edema is one edema which is non-pitting. That we have to mention.
Whereas this is a pitting one, cardiac cause. This is important to differentiate this edema, like Professor Gopinath I told no. Non-pitting, that is the primary. Whereas pitting edema is in secondary cardiac, this is cardiac cause. Okay. So next slide. Penny, next slide. So this is the different. Next slide. Okay, Chandan. Gopinath, anything to comment in this? Because he has told separately whether to tell lateral lobe, both lobes separately, isthmus separately, or they can club together.
You can actually, whenever you explain or describe thyroid swelling, if it has got a beautiful butterfly shape. So I think when you mention this swelling, butterfly shape and dimensions horizontally and in the midline near the isthmus and the sides, it gives beautiful. Whatever you have explained is beautiful.
Yes.
That's you explain properly.
Extent.
You have the total dimension you have to mention.
Yes.
Side to side.
One side to one
Okay, sir.
one of must to other side, and from above, from the wherever it is on the below. Total dimension. And individually we can segregate. But it is the total dimension which is important. Also you have to concentrate.
Yes, sir.
We can do lateral, through lateral lobe, how much it is, isthmus, how much it is. We can mention. Finally, these are nodules in the different parts of the lobule, different parts of the thyroid. Understood?
Yes.
It's a one component. We specify right lateral lobe, left lateral lobe, isthmus. Finally, it is a one component. The entire thing specified. That's what Dr. Gopinath Bhai is expressing. Okay. Individually, we can later put it like that. No problem.
Sometimes you can have one lobe occupying entire neck.
Sorry, sir, the voice is breaking. 1 second.
Next slide, Binny. Well-defined border, skin over the swelling normal, swelling move degradation, and lower border is seen. Decreased nodule swelling. Pemberton sign absent. Robin, anything on this?
Inspection also, they say lower border is well seen. Even on
Yes, sir.
palpation, they have commented the lower border is felt.
You confirm the yes.
And again, they have mentioned that the
Yes, sir.
manium sternae, that they have resonance. So I think these three things are not necessary. When you have a lower border is well seen and felt, the question of doing Pemberton and percussion over the
Pemberton sign.
is
Okay.
not necessary.
Yes.
There's a debate whether to be done or not because may cause sudden congestion. That's also there.
Routinely not need not do so, sir.
Yeah, that's what.
By Physilos method again, only for a short neck. This patient is quite having long neck. So that thing can be omitted. Again,
Short
the
neck, these
lower
patients.
border is well seen. There is question of does not arise about doing Pemberton. Then pulse rate is 78, they commented. Then the question of Brui over the
Yes.
because unless you have hyperdynamic circulation, there is no need to oscillate for Brui. In my opinion.
Yes, sir. But UG level, that's let them. Because
Completely
they got
safe.
some pattern. That's fine. Drill and
Disha, the skin over the swelling, it seems it's a very big swelling. You didn't find any endorsed veins or stretching of the skin or nothing of that sort? You did not?
No, sir. No dilated veins were seen.
Oh, okay. Because it's looks a very big, quite a big swelling. So yeah.
it's quite big actually.
So what is the method used for for knowing the nodularity over the surface?
What method it is called as?
Sir?
Method of palpation.
Lahey's method.
I guess method. Trials.
Trials method.
Trials method for nodule. Leahy's
Nice.
method is for something else.
When you will do Leahy's method, Chandan? Chandan?
So Lyle's method is to when we have to palpate only one side of the node, then we put pressure on the opposite side and then make the lobe which we want to examine more prominent, sir.
You push one lobe, lateral lobe towards opposite side, then opposite lateral lobe rotates, and posterior becomes posterior lateral. Then you can feel the nodules. It's mainly done in solitary nodules. Of course, If there are not much nodules on the opposite side, you can always do that because it rotates like this. You take your rotates and lateral lobe rotates, and posterior becomes posterior lateral. Then you feel it. You have to stand. You have to examine in standing in front actually. Okay, so that is the Lahey's method. Then that is the Kreis method. How we look for nodules, the Kreis method. Okay, right. We'll go to next slide, Robin. Next slide.
Yes, yes.
Right lobe. This is what Dr. Gopinath Pai has told. Individual right, but ideally I think we should together both lobes.
This entire thyroid is one swelling. One gland give dimension from side to side and vertically and at the midline if there is any variation in the size.
Eventually, you can sell right lateral lobes this much dimension. There is segregation. Thing is one mass. Okay, it's not an independent mass. Chandan, Disha, understood? No.
Yes.
Absolutely right. You have to mention together. And eventually, you can mention lateral lobe differently how much it is for your specifications. Okay.
So, but how to write out the vertically?
Vertically,
Landmarks for the vertical extension.
the vertical extension you can tell laterally. Out the right side it is this much, left side this is much. In the center this is this much, like that. Vertical extension.
Highest point of the swelling. You can choose the highest part of it.
Highest part of the swelling also you can mention. If it is right side bigger, you can mention like that.
Disha, you have two bony landmarks and you have two muscular landmarks.
Yes, sir.
You have the HTC, you have the hyoid bone, thyroid cartilage, and cricoid cartilage on one side, the bones. So you can start from the H2, you have suprasternal notch, vertical. And you do sternocleidomastoids, muscular. You have two landmarks on each side. It's very easy. Yeah.
Next slide. So, shape is irregular. Okay, vertical. The same thing you have mentioned again. Same. How much it is? Same thing I think, Robin. Whatever they mentioned.
Yeah, so do we usually say so much in vertically 2.5 centimeters, this that? Do we usually?
How much? 0.7 centimeter above? Not necessary actually. Analyze, but you can little bit reduce the component of these things. Okay. Anyway, it is perfect. They want to do it perfectly. No issue. Next slide. Consistency, smooth to firm. Where it is smooth, where it is, there is no smooth consistency. Surface is smooth. Consistency word smooth is not used.
Soft.
It is soft, firm. Surface smooth or nodular. Okay.
Yes.
So soft to firm, we can tell soft somewhere where it is soft, where it is firm. You know that soft, firm, hard, not smooth, firm, hard. Smooth is for surface.
Yes.
Okay.
What is paradox in thyroid swelling?
What is thyroid paradox? Chandan?
Palpation. I'll give you a clue. Palpation.
Inherent thyroid paradox. Chandan?
Sir.
Swellings be hard.
Cystic swellings are hard. So-called
Yeah,
thyroid. They appear hard.
are hard.
Swellings will be soft.
Soft.
And when the tensely cystic swelling, no, it will become hard. And solid swelling for tumor proliferation, it may feel softer. That is called mainly happens in thyroid. That is called thyroid paradox. Okay. Carotid pulse is felt, swelling or not fixed both. What is that swelling not fixed both horizontally and vertically? Thyroid will not have an independent vertical mobility. Usually we check the mobility along with the trachea. Okay. Independent mobility unless
Infiltration to deep space.
usually will not have an independent mobility.
What is the plane of the swelling? Thyroid swelling.
But you are
One of
not
the
mentioned
common
anywhere.
questions are,
Have we contracted sternocleidomastoid muscle and checked the plane of the swelling? Chandan?
Chandan, Gopi sir has asked a very simple, valid question. What is the plane of the swelling? Just tell us what is normally what the thyroid gland plane of swelling. Then SRB sir has asked, how do you check for the plane of swelling? Two tests. That's all. Simple as that.
Yeah, that's important actually.
It's deep.
That's why it's highlighted very well.
It's deep.
Chandan,
Horizontal mobilities, sir, and we check it.
check it how you have to.
Please check your net. Plane of the swelling is deep. We heard deep. Deep to what?
Deep to what, Disha? Chandan, deep to what? Thyroid deep to what? Deep to sternocleidomastoid.
Pre-tracheal fascia.
Deep facial fascia, right? So you have to contrast sternocleidomastoid muscle and confirm it's deep to sternocleidomastoid muscle. So that's what Professor Robin is showing. Like this, you have to contract against resistance.
Chin test.
Like
So
this,
two
like
sides
this.
at one shot, the chin test, or on one side, you ask the patient to push, you contract one muscle. So either chin test, you to contract both sternocleidomastoids and you see if it's going, or either sides.
This what exactly. So that is important. I don't know. You are not mentioned anywhere. I think Gopi is rightly pointed out. You are not mentioned relation to sternocleidomastoid. See, key muscle in the neck is the sternocleidomastoid muscle. For any swelling, when you express, you have to always express in relation to the sternocleidomastoid muscle, and that holds good for thyroid also. Okay, so contraction of sternocleidomastoid muscle and checking the relation is very, very crucial and important. That is you cannot avoid. That is very, very important. Okay, so next slide. Gopi will go to the next slide.
Yes. Now one more. Before that,
Okay.
he has not mentioned about trachea. Trachea on palpation.
He said that is
And
not good.
Also, Cocker's test. It's such a big goiter, and with the history of dyspnea,
Cocker's test.
and he said it is not toxic.
What is Cocker's test, Chandan? How to do that?
Sir, it is used to like bilaterally. Using two fingers, you need to thumb and index. We should compress from lateral part of the.
If you bilaterally use it, you're strangulating the patient. The patient is already having dyspnea. His
Sir,
trachea
from
is
one,
not, trachea is from one side you try to push, laterally you shift. And
laterally,
you
and we
look for the,
and we look
Posterior
for
medial you
stridor.
dissect and what they develop? What patient develops?
Strider.
Strider.
what type of strider, Disha?
What type of strider it is?
You have inspiratory, expiratory, mid-expiratory, none of the above.
Right.
Simple question, simple. Like imagine you are breathing, just don't try to mug up. Surgery is very easy. Surgery is just common sense and anatomy. That's all. No other subject.
I tell them surgery is easy to forget also. I tell them, Rahul. Easy to understand, easy to forget.
I always give the explanation of a thin straw and a thick milkshake.
That's it. Very easy to remember.
Very easy.
Yes.
Easy to remember. Yeah. So,
Inspiratory, Disha. Inspiratory.
it's inspiratory. Okay.
I think for tomorrow onwards, I think you should try going to the ice cream parlor shops. There are very good shops in Mangalore. I have visited when I came to meet Esther. Beautiful shops are there.
So, it's an inspiratory strider. What it suggests, Disha? Chandan? It suggests what?
Sir,
Suggests what?
What's the inference of Cocker's?
Strider
What is the
suggests-
inference? What do you get?
that there is infiltration.
Suggests what? It suggests trachea Malaysia. About trachea.
Yes, Trichomalacia, sir. Trichomalacia, because of a long-standing large mass in
Yeah,
front.
thyroid cartilages getting weakened. So this weekend when you operate, they require tracheostomy. So you have to inform the patient party. They require
The
tracheostomy.
anesthesia.
Yeah, okay. Whether this tracheostomy is permanent or temporary?
It can be temporary.
It is temporary. Okay. Usually it is temporary. Usually, how long you'll keep the tracheostomy in such situations?
We try to extubate and just
2 to 3 weeks, sir.
develops strider again.
Don't explain those things. Total 3 weeks. Okay, once there is a rider, you have to do tracheostomy, you have to do tracheostomy. You don't explain anything. You have to keep it for usually for 3 weeks. By then, ring will regain its strength. That will be sufficient. You can close the tracheostomy. Okay, so it's for 3 weeks. Absolutely right, Chandan. Okay, there's no debate. Very clear
What
concept.
is this absent carotid pulse in goiter?
That is called berry sign, sir. Berry sign.
What is it? Where do you palpate this carotid artery?
Sir, when if the at the level of thyroid cartilage, sir, medial to sternocleidomastoid, sir.
You know, every artery should be palpated against a bone.
Against the C6 transfer process of C6, sir.
There's a tubercle called some name for with that. Any name you remember? It's academic wise, literature wise, there are so many people against that. But still, it is mentioned in the books. What tubercle?
There's a tubercle there at the transverse process, an unusual, very long.
I don't know the name, sir.
French term.
Any name
French
you remember for that tubercle? In the transverse process of C6, whatever, carotid tubercle. Yeah? And then, it's called disagnate tubercle. Disagnate tubercle. Go through the book later. Okay.
Guys, just to complete what Gobi sir has asked, carotid pulse is very important. Whether it is a benign problem, because like your palpatory test, like we had pointed out, it's missing a lot of things. You start off with local rise of temperature, tenderness, size, shape, skin. All the SSRO, number of swellings. Border, very important, is the lower border, which you are confirming from the inspectory. When you come down, the tests are very important. Leahy's method, Kreil's method. You have Cockers. Then you have the last one you put it as Berry sign. That's only Berry sign. Now, what is the inference of Berry sign? Just for your information, you have a benign problem and you have a malignant problem. You have mentioned that the carotid pulse is felt. The questions the examiners will ask you is, first, like Gobi sir has asked, where will you feel it? Very simple question. You have to just answer the question that's all. So, what is the inference of this point? Why is Berry sign important? Is it shifted from its normal position? Normal from the imaginary line from the upper border of the thyroid cartilage to the mid of the sternocleidomastoid is the transverse process C6. This is the point. So from here, is it shifted? There are two diagnoses you have to answer to the examiners. One is a benign problem, one is a malignant problem. Where do you find it? There's a subtle difference between the two.
Suppose there is
sir, in benign mass, you can feel the pulses above it, like in the superior temporal artery and all, you can feel, sir. But in malignant, due to infiltration to the carotid sheet, we may not.
Just to make it clear, so in a benign, long-standing, large goiter, there is a shift. There is no absence. There's a shift, a lateral displacement. So it is there. You will feel it. That's all. So, but when it comes to malignancy, it's a different thing. It's an infiltration. It's encasement of the sheath. It's an encasement of the sheath. So it is there, but you're not able to feel it. That's the difference between them.
Whether it's shifted or in case it becomes very sign. Shifting is
benign conditions, there is push.
Yes.
Benign conditions, it is pull, either engulfment or infiltration.
Yes. Very good. Very easy to remember.
Okay.
Yes.
So, cervical lymph node not palpable here mentioned. Next slide. Percussion or resonant note is heard.
Guys, just to save time, you can note it down. The group of lymph nodes you should know for thyroid. Which are the drainage group of lymph nodes that are important, because when it comes to carcinoma thyroid management, we will definitely ask you something, a basic of neck dissection. So you should know which are the drainage points. Is it 2, 3, 4, 5, 6, 7? Is it central, lateral, but which ones? Just you can note down somewhere. We will probably, just to save time, we will.
2B, 3, 4, 5B, and 6, 7. 6 mainly.
6 and 7. Yes, 7.
Exactly. These are called as lateral neck nodes. These are called as central neck nodes. Central neck nodes are called as primary thyroid nodes. Lateral neck nodes are called as secondary thyroid nodes. Okay. These are the primary, is central, level 6. Whereas these are the secondary neck nodes for thyroid. Okay. So that's what you have to remember. Drainage, lymphatic drainage of thyroid, primary, secondary, central, lateral. Primary or central, lateral or secondary or lateral. Okay. That is how exactly Robin is highlighting. So sternum. Okay. Next slide. Benny, next slide. Vertical lymph nodes, this is they already mentioned. No Bree, sir has already told Bree whether to, but for UGs, for completion, we'll accept it.
Yes, sir. Just for
In the
completion's
topic.
sake, yes, sir. One of the examiners will pick on that.
Next slide. Benny, next slide. Normal boil, turns hard. No, abdomen, organomegaly, which organs you are interested?
Liver.
Liver and spleen, sir.
Why
Liver
why
and spleen. Why liver? Why spleen? I agree with Disha about liver, but I don't know about the spleen part. That I heard for the first time. Unless you have something to justify.
Follicular carcinoma will spread to secondaries will be seen in liver or lungs or bones.
No, we asked about abdomen. We asked about abdomen, we didn't ask about chest.
Okay.
You said liver.
Why spleen? And then why you want to examine spleen?
Why spleen? Which is the other malignancy classification? That might involve the spleen.
Why you want to examine spleen in a thyroid patient? At least there are situations where you need to examine. Two conditions. Their splenomegaly can occur.
Papillaries.
Malignancy told. Tell two conditions. Remember, splenomegaly can occur. One is grave disease. Hashimoto thyroiditis, because they are both are autoimmune. So splenomegaly can occur. That's what you have to look for. Okay. Remember. So next slide.
Thyroid lymphoma.
Thyroid lymphoma also, splenomegaly can be there. Summary, they have told detailed summary. Next slide. Next slide. Next slide. Okay. The same thing they have told actually in detail. Summary,
Yes.
they, I think they brief it. They put it again to make it very concise summary. Okay. Everything you have rewritten actually. Next slide.
One slide, just one slide for summary. That's always the main positive findings. That's all.
Continuous flow of sentence. Continuous sentence it is. Summary is not 1 by 1, 2, 3, 4. It's a single sentence continuously should write. So that
And guys, you have two provisional diagnoses. You have a provisional diagnosis there which is benign thyroid mass, which is non-toxic, and now you have again a provisional diagnosis. You can't have two provisional diagnoses. So previously hyperthyroid, but the patient is already having palpitation, insomnia, everything is still there. So your thyroid, we find it very difficult to digest that. I think.
Gopinath, anything, any comment on our original diagnosis?
Actually, before commenting on these things, I just wanted our students to examine toxic signs. So whatever toxic signs, even in primary, in terms of tremors and in terms of fasciculation in the tongue.
Yeah, that's it. Yeah,
So
that
more common in primary, but even then, when the cardiac pulsations are normal now.
Yeah, that's a tremor they have not mentioned. Have you mentioned tremor anywhere, Chandan or Disha?
Yeah, we had mentioned.
No.
So that is important finding. I don't know. I also forgot to mention that. Gopinath is absolutely right. Tremor and the tongue examination. You have to put the tongue inside, not outside. Tongue within, you have to check for the fasciculations. Okay. And hand tremor, like stretching like this, you have to check outstretched hand. So that is in general exam. Somewhere you can put actually for toxic features. So you have to specify that is should be, that's one point important. So you said non-toxic in the history. You said hyperthyroid state. Now euthyroid, why you said? Because there are few features going on. You said sweating, all those is there. Probably propanol they have added. You have not mentioned that whether she was evaluated earlier before putting the propanolol. You should have asked that there are not blood test in specific. Probably might have done the T3, T4, TSH. You have not asked. There are certain things. So next. Okay. Gopi, anything to about these investigations? Ask any specific questions, Gopi? Gopinath?
Sir, actually basic investigation CBC is a must here, because this lady is having all sorts of problems since last so many years. So CBC not mentioned here. Apart from CBC, third function test.
Chandan and Disha, blood count is important once you have highlighted the toxic thyroid. You have put toxic thyroid somewhere, that blood count becomes a specific test actually. Why? So that's what Professor Gopinath Pai is telling, blood count is not mentioned. Why total count is important before starting anti-thyroid drugs? Why you want to know the baseline total count before starting anti-thyroid drugs? Suppose if you want to start anti-thyroid drugs in this way, what's the side effect of toxic effect of the anti-thyroid drug? Suppose if you start carbimazole, they go for bone marrow suppression, no? Agranulocytosis, no? So that's why you should have a baseline total count or blood picture. That's what Gopinath Pai, that CBC should be added in all thyroid cases, okay? This is a relevant investigation, specific. I know routine, specific. There is a specification usually have, and the routine can skip, of course. But here
So they mentioned that the patient is pale, sir.
oh, okay. You can mention this pale, then hemoglobin also comes into the picture. So CBC, all the reason to add CBC, don't skip that. It has got some relevance, and okay, and especially when you think it is a toxic and other things, okay, right? X-ray neck, why you're told?
Always the investigations, routine basic investigations, which have all the basic hemogram and all that. Imaging, specific investigations, which has your triple assessment, the core triple assessment, and then you go to the staging for the malignancy. The
Yeah,
three different.
When you write routine, then specific. You may discuss what specific, but when you write a case sheet, routine also important. If it's for eventual management, here it is specific also. Because starting anti-thyroid drugs, you need to know. So always write a routine and specific. Understood? Present yourself specific. We may discuss only specific evaluation method, but your job is to write both. That's the important thing you have to remember. Okay. Why you wanted to check? Do
Sir?
X-ray. Why you want to do? And then
Sir, to check for trachea malacia, or some, because we couldn't feel the trachea on examination because of the swelling in front. So lateral view will help us.
okay. If it's malignancy, anything else want you look for?
Calcification.
What
sir.
type of calcification you want to look for?
Grain like calcification.
Microcalcification. What is it called? Otherwise, pathologically? Pathologically, what it's called as? Carcinoma bodies?
Yes, sir.
It's some of body.
Next slide. Right. Surgery, this is what will Robin.
When you plan such a huge gland, sir, when you plan, you intend to do surgery, I think investigation should comprise that laryngoscope, vocal cut.
Laryngoscope you have to add on to before, because in all thyroid, before starting treatment surgery,
Indirect laryngoscope.
indirect laryngoscope at least. Now, of course, you got a fiber optic laryngoscope. Video laryngoscopes are there where you can see the larynx. You can take a record of it, document it also. But at least indirect laryngoscope is important. Vocal cord vision is essential investigation for all thyroid. Like Manoharan Sir has highlighted. Gopi, I think Gopi, you also will agree that should be included. I think so. You should write always laryngoscope, whether it's indirect laryngoscope at least, or specifically video laryngoscope if it is available. You should visualize the vocal cord. That's a very relevant point, Sir has mentioned, that you did not skip in investigation. That's important. You have to write. Okay. So
Yes,
we will just discuss about the malignancy concept, because we had earlier discussion all these multinodular goiter, everything in earlier thyroid sessions. Robin knows that. Now Disha and Chandan, suppose this is a papillary carcinoma thyroid. FNAC, you said written FNAC. FNAC comes as a papillary carcinoma thyroid. You tell the management concept. Professor Gopinath Pai is there, Robin is there, Sir is there. Just express your use, management aspect. Papillary carcinoma thyroid. FNAC report has come like that. Chandan or Disha?
Total thyroidectomy with that level 6 Lymph node should be removed.
Okay, so okay, central compartment dissection. Okay, Gopi, you can ask question, no problem.
How does papillary carcinoma spread?
Lymphatic.
Lymphatics.
Lymphatic spread, isn't it? So differentiated papillary carcinoma along with thyroidectomy. Anything else you are
Lymph-
supposed to do?
Lymph node resection.
MRND, modified radical.
Central lymph node dissection.
Okay, central lymph node. There are okay.
Yes.
But you can explain actually because they are.
Okay. All right.
If it is malignancies, then if clinical nodes are not palpable. What Disha? So there are no nodes, so you go for CT neck. So whatever minimal nodes which are not palpable, subclinical nodes also will be picked up by CT. And as per Sir said, go for total thyroidectomy and do the relevant node dissection.
Either MRND or lateral neck node dissection. Earlier, Robin sir has asked, told no, level 2, B, 3, 4, 5, B nodes. These are called lateral dissection with a U incision. And of course, many times now onco surgeon go ahead with the central compartment dissection also. Okay, that is the primary lymph node. The secondary, if it is positive only, will do it. If it is negative, will not do it. So prophylactic lateral dissection is not there. Prophylactic central neck dissection is possible, and many patients they take it because the involvement of central neck central nodes are very common. 85 to 90% of the thyroid malignancies, central nodes are involved. Eventual histological finding. That's a lateral dissection done only if it is positive, either sonologically or FNAC wise. Okay, so it should have a sonological features. What is thyroids? Heard about thyroids?
Yes, sir.
What is the full form? Chandan? Chandan is finding it difficult to connect. Chandan, what is thyroids? You heard about thyroid, Chandan? Chandan? No, he's fine. Disha, you answer because it's some network problem. Disha, you answer?
Yes, sir. Thyroid imaging, reporting, analysis.
And data system. RADS same, reporting and data system. In the breast, it is birads.
Thyroid.
There are 6 components. In thyroid, it is thyroid, TI. RADS is same, reporting and data system. Here it is thyroid imaging. There it is breast imaging. Like birads, it is thyroids. Here it is 5, there it is 6. Understand the difference? Birads, it is 6. Here it is 5. So 5 it is malignancy, susceptible, less susceptible, like that it is there. We can always go through those things. But remember, thyroids, pathologically, thyroids is important. And what is quadruple assessment? But breast is a triple assessment. Here there are quadruple assessment. What about quadruple assessment in thyroid? History and
Clinical
examination,
assessment.
imaging, FNAC, and biochemical analysis. In the breast triple, it is here a quadruple. We add on to T3, T4, TSH also here. So thyroid quadruple assessment, breast triple assessment. So how to manage if it is lymph nodes are there? After that, what you will do? Will you reduce therapy or not?
Yes.
How much? How will assess the patient radioiodine therapy or radioiodine therapy?
The TSH levels will be high in this patient, so we'll have to give them suppressants.
Okay, suppression. How much dose? What is the dose of suppression therapy?
It is
It is okay. High it is 0.3 milligram once a day. Okay.
3 times.
So, what is the prerequisite for radioiodine assessment? How much TSH should be there for radioiodine assessment? Do you know that? How much? TSH is more than 30. Correct. More than 30 should be there. So, Robin, they have told total thyroid to me because carcinoma thyroid, they are confusing. They are getting confused. So, shall I go through my speak slides, Robin?
Sure, sir. Yeah, I think they have covered all the main things. So by the time you load, we will just hit Gopi sir and Manoharan sir. We will just try to field few points. Guys, everything is okay. So treatment, your carcinoma case, main treatment modality is surgery. There is no doubt about it. That is curative. There is no question of saying subtotal, no hemi, no partial, no lobectomy, no isthmusectomy, nothing. This is a classic from subsistent for postgraduates. There's no doubt. There is total. Second point is if clinically or on imaging, you have lymph nodes, you proceed for central neck dissection. If lateral, yes, because the mortality is very high. Second point. Okay. Once this is done, you send it for biopsy, find the thing, everything is fine. You have to go for radioactive iodine. Two main indications for radioactive iodine therapy. We don't have time now, but please note it down. I've said two. There are two main reasons why we go for radioactive. What is the prerequisite for that? Sir has already asked you. You have to go for the TSH level, mainly. At undergraduate level, you should know what is the suppressive dose, what is the maintenance dose of thyroxine. And if such a thing happens also, supposing we can't get the TSH level to be high because it has to catch the radioactive iodine, yes, what are the two mechanisms that we will use to make the TSH up? Simple question. One is a very simple answer there, and the other one is a little bit high-fi for you, but you should know for the NEET exam. So radioactive iodine is also done. The last point for carcinoma thyroid is chemotherapy. There is only one drug that is FDA approved that you should know for the NEET exam. That's doxorubicin. There are a few other drugs which is a little bit high-fi for you because you should know for the NEET exam. The tyrosine kinase inhibitors you should know. It is actively practiced in onco centers. So it's very easy to remember: surgery, radioactive iodine, and chemotherapy. It's very simple.
Gopi, anything to any advice to the students before I quickly go through my slides?
The only thing is they should know whether it is follicular carcinoma or papillary carcinoma. Both require total thyroidectomy, and then one should go behind deposits or residual thyroid. And they also should know if after biopsy, after hemithyroidectomy or septothyroidectomy, if report comes as malignancy, again, what is supposed to be done? They have to mention about completion thyroidectomy. And then look for notes, and depending on the notes, do proper surgery. Like what Robin sir has told, you have to think in terms of radioiodine, special dose of thyroxine, and then chemotherapy or tyrosine kinase inhibitors. All these according to the diagnosis and presentation.
Yes, sir. Everything covered, but remember FNAC is not useful in which carcinoma?
Follicular.
Because that you have to remember.
Why it is so? Why it is not useful?
The invasion of the capsule and the
Angio.
Yeah, that's
Very important. Neoplasm is infiltration, vessel, angiogenesis. No doubt about it. It's very easy to remember.
for complete check, you must remember the tumor markers. What are the tumor markers of thyroid malignancy?
Tumor markers
Anyone?
important for follicular carcinoma thyroid and for medullary carcinoma thyroid. For follicular carcinoma thyroid,
Just mention. That's all.
simple.
thyroglobulin,
Thyroglobulin.
Yeah.
For medullary
Very
carcinoma thyroid, and then
calcitonin.
absolutely perfect. If you remember these two, that is fair enough.
Yeah, Disha, very good. You have answered all the questions. Because of that, I will ask one more by the time SRB sir loads his PPT. You have mentioned very well that thyroglobulin is for follicular carcinoma thyroid. You have also mentioned that calcitonin is the marker for medullary. Can you give us one more tumor marker for medullary carcinoma thyroid?
CEA.
Yeah,
Absolutely right. Yes,
Perfect.
absolutely right.
Right.
Very good. Yes.
That's right. So overall, they have presented well, Robin, sir.
Yes.
I think they took to online with all unknown senior professors. So they managed to get the question and think and answer. It's absolutely perfect. Good, actually.
Very well done, sir. Disha and Chandan. Both of you did very well.
They have presented well. They have done well. Absolutely.
Thank you, sir.
Not that easy to face online sessions like this. Absolutely perfect. They prepared and they're maintained calmness and answered, thought and answered. Absolutely. I think. Quickly, I'll go through my slides, Gopi and sir.
Yes, yes.
I mean, next slide. So history, I'm just thinking in name, age, occupation, residency, all these things are important. Derbyshire neck, Himalayan goiter belt, all those things to be asked in the exam. Next slide. So thyroid is the only endocrine gland which is properly accessible clinically, only gland that can be involved in all age groups, only gland where malignant tumors are mostly non-functioning. Remember, functioning malignant tumors are very, very uncommon. Next slide. Next. Chief complaint. Next. So all these things are in order. This is what we have discussed already. Go back 1 minute. Pain, hoarseness, weight loss, appetite. We have discussed tremor. Sir has told, Gopi has told, tremor is important on examination that should be highlighted. We have highlighted all these things. Next slide. Next slide. So I'm just putting the swelling, pain, fever, other lump, pressure symptom, toxicity, symptoms of hypothyroidism. Families, again, family tree, everything we have discussed. Past history of swelling, treatment, surgery, thyroxine, antithyroid drugs, and other drugs which may cause toxicity or may cause hypothyroid and all those things. Menstrual history, affect history also important in females. Another thing which we forgot to mention is male thyroid is commonly malignant. Remember, uncommon thyroid enlargement in male is uncommon, but it is more likely to be malignant. So surgery is the priority for males. Remember, male is the high risk group. Next slide. Benny, next slide. Benny, next slide. Next. So inspection, again, same thing, movement, why Berry's ligament, all those concepts, please read it out. That's important. What is the condensation of deep fascia above and superior? Physiological method, sir, we have discussed WHO grading, all those things. Kreis method, physiological method, Cocker's, OPS, Gopinath Pai discussed promoter sign, whether it's needed or not. Brachial trail sign, we have discussed lower margin importance, we have discussed Leahy's method also, we have discussed trail superior pole, Brui, plane of the swelling, important, which you have missed actually. Gopinath Pai and Sir, Robin and Manoharan Sir has highlighted, it's very important, fixity, Sarnocard mustard muscle contraction is important. Thyroid the pulsation, we have discussed actually, where to, how, what tubercle, Chysagnia tubercle, all the details we have discussed actually. Next slide. Next slide. Benny, next slide. So other oral cavity scalp, tunnel percussion, tenderness, auscultation, cervical lymph node, systemic examination, abdomen, scalp means, I'm sorry, skull it should be. Skull examination important because the follicular carcinoma thyroid may cause secondaries in the skull, pulsatile secondaries. So always examine skull and spine and bones because bone secondaries may be pulsatile, soft, all those things. Okay, next slide. So ankle jerk, skull, spine. Next slide. Benny, next slide. Benny, next slide. Benny is slow today. In multinodal diagnosis like this, you have to put left thyroid, euthyroid, non-toxic, toxic. Everything you should specifically mention. Next slide. How we will manage? Next slide. There's the question. Quadruple assessment. There's a word usually exam they will expect you to answer. What is quadruple assessment? Like triple assessment in the breast lump. Here it is a quadruple assessment. I have told history and clinical examination, phonological examination, FNAC, and biochemical evaluation T3, T4, TSH, and treatment. This is the master chart. This is the next slide. Very next slide. So thyroid movement to the glutation, lower border, butterfly shape. But somebody already told actually, Gopi has highlighted that. Trials method, Sarnocard mustard muscle examination. Next slide. So this is from behind you have to examine muscle, trials method, trachea examination. Next slide. Next slide. So toxic thyroid, this is the Leahy's method of examination. Again, pulse, thrill and pulsation, Mobius sign, one grief sign, all those things we have discussed. Like tibia, edema actually, Dr. Gopinath Pai has told edema, we have two different types. He has discussed actually. Same thing I am putting, toxic thyroid, primary toxic, you can see that in the extrathermos. Next slide. This is the Joffroy sign actually. This is the Navigator sign. Navigator sign, Joffroy sign. All those signs are very clearly Mobius sign. All these four signs are important. Navigator sign is like this. Joffroy sign is like this. This is a one grief sign, Mobius sign. Next slide. So this is but different types because these are could be malignant. Remember, this is the toxic thyroid. Next slide. Solitary nodule, multinodal. See, this is the malignant thyroid. This is the malignant male. See that mistake you can see. The male thyroid is likely to be malignant. Remember always. The lingual thyroid is again malignant thyroid coming out advanced stage locally. Next slide. So remember all these things I'm not mentioning: functional state, compression, neck node, trachea, feature malignancy, retronutrition, cardiac abdomen, respiratory, everything we have discussed, like bone secondaries, trials method, trials grading, that also we have discussed, serum calcium, ultrasound, ILS, we have discussed actually. Gopi has told, somebody told, Robin has told, in a vocal, Sir has told, like vocal cord man important. Radiotherapy, technetium scan, MRI also we discussed, thyroglobulin we have discussed. Thyroid paradox, somebody has asked actually. Actually, I think Gopinath has asked. Lateral, these are the different things you have to remember as far as relation to the thyroid. Next slide. Next slide. I'm just going through the Dunhill classification. This is what you have to remember: differential thyroid cancer, papillary carcinoma, pulmonary carcinoma, and anaplastic, medullary carcinoma, thyroid lymphoma, secondaries. Next slide. I'm not going to detail. I'm just put the chart. Next slide. Benny, next slide. Good evening, Benny. Next slide. PCT spread through lymphatics, FCT through the blood, anaplastic by both, MCT blood and lymphatic. That's the short forms you remember, but this is the chart. Right? Next slide. So this is the male thyroid. See that etiology, all these things are we have discussed already. Codin syndrome, other complex, everything Robin has discussed. Next slide. So PCT, commonest one is the papillary carcinoma thyroid. All those things again we have discussed the types. You can always read. MCQ questions will be asked. And the spread is mainly in lymphatic, lymphatic spread. Again, we have discussed firm, hard, thyroid paradox. We have discussed any thyroid can be malignant unless proved otherwise. Independent of size, duration, age, all those things. That point you have to remember. Distant spread is common with when it is more than 4 centimeters size criteria. Next slide. So ultrasound neck, UHGFN is supposed. I have not put blood count is important here. Gopinath Bhai highlighted that, very crucial. Thyroids I have told 1 to 5, 5 are there. I like biroid 6 are there. Next one. Treatment is rotothyroid lateral neck dissection. Suppressive dose help 0.3 milligram. I told. Hemithyroidectomy only small size. Then you do a follow. All those gradings are there. I'm not going to discuss that. Prognostic grading. You can read the book. My book it is there. Table is there. Next slide. Next slide. So follicular carcinoma is less common. Remember, commonest is papillary carcinoma thyroid. De novo or in multinodular blood spread is skull, pulsative secondary skull. Non-invasive, invasive, two types are there. Capsular vascular invasion, we have discussed that, angio invasion, Hyder, hoarseness of eye, dyspnea, everything we have discussed. Berry sign we have discussed. FN is inconclusive. Sir has told that. Frozen section biopsy again is not fully accurate. Next slide. All this we have discussed actually. Just pressure putting in the chart. Phototherapy, radiotherapy therapy, maintenance dose of L-thyroxine. Robin has highlighted that. Follow-up thyroglobulin estimation, ultrasound neck regularly, guided aspiration, TSH more than 30. Again, he has specifically told. That's a crucial MCQ question. Remember, iodine ablation, thyroxine therapy. Next. So differential thyroid cancer is a terminology where papillary and follicular together it is called a different thyroid. Around 90% of malignancies are DTC. So TNM staging is there. I'm not going to discuss. Aging is different for below 55 and above 55. So age is 55. Earlier it was 45. Now it is 55. Remember, so you can read it in the book. TNM staging and central comfort dissection. Gopi has told actually complete thyroidectomy, suppressive dose, cardiac osteoporosis, manage metastatic disease. Again, Robin has discussed targeted therapy, chemotherapy, external radiotherapy. Everything has discussed. FNAC, TA. These are the thyroglobulin antibodies mainly for. If it is mainly for lymph node aspiration, you can take PET-CT in advanced cases, or if there is a persistently increasing thyroglobulin level in the post-surgery, you do a PET-CT. Okay, next slide. So remember FCT, radioablative ablation, precautions before radioactive therapy. The salivary, urinary, take plenty of water, otherwise bladder cystids can develop. Then same thing, salivation is important. Take lot of chocolate they have to take. Then excreta disposal is important for a week and so. Remember, arterial cell carcinoma is a very, very aggressive type of FCT. And chemotherapy, of course, advanced adramycin. Traditional time, no. Otherwise, adramycin is there. And next slide. Next slide. Benny, next slide. Okay, anaplastic, as we already discussed, undifferentiated, aggressive, lifespan is short, very sign. Go back, Benny. Always stage 4 it is. Remember, anaplastic stage 4. maybe A, B, C there. A is operable, B and C is not operable. Always there is no stage 1, 2, 3 for anaplastic carcinoma. Always anaplastic stage 4. A operable, B and C not operable. See, this adrenomycin tracheostomy may have to do in this patient. MCT mainly it is not parafollicular cells, MEN syndrome, familial, sporadic, amyloid stroma. Calcitonin is the main tumor marker, MEN2 syndrome. No radioiodine study and therapy because it is parafollicular T cell, not follicular cells. Okay. Familial, hereditary important, presentation like a nodular thyroid, diarrhea and hypertension. Examine the abdomen because pheochromocytoma may be there. Evaluate for pheochromocytoma by VMA, other chemical evaluation. Screening all family members by calcitonin level. That's important because they may go for, they may have to do a for prophylactic thyroidectomy in this patient. Next slide. Benny, next slide. And finishing tomorrow. This is the malignant thyroid. She was in our hospital operated. Next slide. Benny, next slide. Benny, next slide.
Says there, sir.
So
Slide is
is
not.
it raining in Mangalore? Is it raining in Mangalore?
It is raining. It is raining. Actually, that's why. I think.
Here we've since 2 days we're having thunderstorms and rain in
We
Kerala also.
had evening
So
thunder.
net is very the internet is very hazy here also.
Okay. Over actually. Next slide. Benny, next slide. I'm not seeing, but it's okay. So, Robin, this is the central dissection and other dissections. Next slide. This is central dissection, lateral dissection, these components for food and purpose. Next slide. This is the malignant thyroid operated. Just want to put the slide of the Emil Theodore Cocker, the surgeon who got Nobel Prize, did extensive work on thyroid surgery, Robin. Gopi, you know that. So this is the neck thyroidectomy with the lymph node dissection. This is a specimen. Next slide. So that is a brief about carcinoma thyroid. Most of the things we have covered. Actually, let them read. So my book, Clinical Methods in Surgery and Manual of Surgery, I request everybody to go through that. And I request every students who have joined, subscribe my channel. Daily small brief lectures are there and live sessions we are having once in 3 weeks, once in 2 weeks with the senior professors there. Robin is there, Manoharan Sir is there, Gopi is joined today. So I request all students to subscribe my, it is free actually for their benefit. And my books, Manual of Surgery and Clinical book, please go through that for all detailed about the thyroid or any topic in detail. So my digital lectures also there. These are my websites. Again, conclusion, they have presented well, Robin sir, Gopi.
Yes.
And details.
Yes, sir. Very nice, sir. Both
Very
of
nice.
them. Congrats to both.
At their presented it is good.
Sure.
Again, they can read my clinical methods and book and my manual. Everything is there in detail, whatever you have discussed. I thank Manoharan sir for being with me because he is not feeling.
Thank you, sir. Thank you, sir.
I thank Gopinath by HOD because
Thank you,
he's
sir.
still there. He is joined with me. Gopi, very nice of you. Thank you. Because just 2 days back, I requested him to join. He immediately told he will join. And,
Thank you, sir. Thank you very much
nice.
for giving me an opportunity.
Yeah.
Wonderful platform.
Thank you.
Thank you, Gopi. And thank you, Robin. You're always with me. Next time when you come, Mangalore, come home for food.
Definitely, sir.
So,
The UG exam is about to start, sir.
Thank you, sir. Manoharan sir, thank you.
Yes, sir.
We'll have next session maybe after 2 or 3 weeks. Just
Yes, sir.
confirm.
Yes, good. Sir. Yes, I
Sir,
think I think Eid is coming up. I think after 2 weeks.
okay.
I think yeah.
We'll just avoid those days and we'll
Yes,
go.
sir. So the new
And
we are
of
expecting
course,
the new batch. The posting is not order is not come yet. And yeah, we are waiting for that.
Yeah, so thank Disha and Chandan. They presented well prepared. Initially,
well.
they had tested, but they can adopt the things. Thanks, Binny and of course, IT people. Shreya is there. Then Aditya is there, always there as a supportive for my IT work. And thanks everybody. And next session we'll have some other topic. And again, request students subscribe my book who are joined the YouTube. They will get a certificate who are joined. Like Robin, we are sending the certificate on mail. And let them
So
join.
just a second, sir. So Benny or Adi, the students from, I think, Dubai are asking for the upload for the certificate link. Can you just put it on YouTube, or they're asking? Yeah, okay. I think the
I'll just clarify with the Aditya. If they not put last session's certificates, and Benny
yes, so
also.
feedback form, and they're just asking because they want a certificate for the attendance.
Yeah, definitely we'll send it. I will just work on that. I'll discuss with them. We'll definitely send through email or through some method.
Yes, sir. Yes, sir.
So
yes.
you can request Benny and Aditya, make sure that these students who are joined, they'll get their certificate. That's important.
Sure, sir.
Also, okay. So thank you, everybody. Thank you for spending 1.5 hours with us. Gopi, thank you.
Thank you, sir.
Sir, Gopi,
Thank you, Dr. Thank you, Dr.
Robin, thank you.
You, sir. Thank you.
Manoharan, thank you very much. Robin, you take rest. I know you are busy. Sir,
yes, sir. We are on duty today, sir. The kids are calling on the phone. I'll just go and attend.
Gopi is always
Yes, sir.
very helpful to me for all my this one. Even when I was HOD, all CMEs used to come whenever I call. He always tell I am there with you. So very kind of you, Gopi. Thank you,
sir. Thanks.
And Disha and
Okay, sir, it is first time I'm meeting you. I hope to meet you in Bangalore when I come.
Definitely, sir. Yes, I'll come to Kerala, sir. I'll come.
Definitely, sir. Definitely.
No, sir. Thank you.
For UG exams, you can call, sir. If possible, I will join.
Sure. Thank you, sir.
Yes, sir.
Sir will come all.
Yes.
Even Robin.
Chandan and Disha, very good presentation. We wish you good luck for your exam. Yeah, we hope you do very well.
Thank you, sir. Thank you.
Presented well.
Yeah.
It was a good session.
Thank you,
Hope students will understand and go through this one because everything we have covered. I think most of the things.
Yes,
I think Sir and Gopi and Robin, you have discussed everything in conclusion. Actually, most of the things whatever I have put in the slide, you have discussed actually. So because it's a long case for them, and the theory also they will have short notes will be there, main questions will be there, MCQs will be there, and they'll put in Oxy also now.
Yes.
Examination method. It's a usually long case also. So everything is required. You can read my clinical method and manual also for better understanding. So thank you everybody again. Good night.
Yes, sir. Good night, sir.
And Manoharan Sir.
Thank you, sir.
Isha and Chandan. Thank you. Take care.
Thank you, sir.
Good night. Take care. Hope
Good luck, guys.
useful to everybody. Thank you, sir. Thank you.
Thank you, sir. Thank you. Good night, sir. Good night. Thank you.
Thank you, sir. Thank you.
Thank you.